right, this is a patient case that I recently had that I wanted to share with the world. Hopefully, get some good discussion, um, questions, comments, critiques. And I just wanted to raise awareness too that a lot of times problems in the hip, knee, foot, they're not actually hip, knee, foot problems. A lot of times it's coming from the lumbar spine. And everybody in rehab has heard that. They're taught that in school. Make sure you rule out the spine or screen the spine. But I don't think a lot of us were given much more detail than that. Like how do you do it? How do you do it efficiently? And that's something that I've just recently started to get better at. So kind of go through my thought process a little bit. All right. So this patient came to me with referral of pain in unspecified knee from a orthopedic surgeon who will not be named. So I went to that ortho's note to try and get some more details to kind of prep my note. And turns out it's the left knee and it's a sprain apparently. He did have x-rays taken of the left knee, showed something floating around in his knee, a little something. Not sure if it's relevant or not, says the radiologist. Please clinically correlate. All right. Also, so we're getting into the subjective exam interview right now. He's a mechanic, and unrelated to why he's here today, he dropped an engine block on his right ankle. But it's healing. He's walking and everything. Left knee symptoms, he described them as sharp, shocking lateral left knee / thigh pain. And it's also throbbing. There's two clues in this sentence that made me suspect the low back as the origin of symptoms. The fact that the pain is described as shocking, and the fact that it went into the thigh. Now, he didn't immediately volunteer this information. It's important to ask follow-up questions. And I asked him, do you have any pain above the knee or below the knee? And that's when he told me, yeah, it's in the thigh as well. Started about 2 months ago with no apparent mechanism of injury. Made better by laying down, icing, hot shower, muscle relaxers. Made worse by prolonged standing, sitting after standing, stairs. I don't think he verbally told me about the stairs. I think that's something that information that I got from the LEFS questionnaire that I had him fill out. And that's always nice because we have stairs in the clinic, and that can be a good functional baseline. I always ask about patient unique goals. He wants to walk more with his wife. Ruled out anything more serious, no constitutional symptoms or falls. But he has had the knee lock up a few times. And he's got some bowel issues that he's had for years and has not changed, so I don't think it's relevant. So next thing, I wanted to see, he's been sitting for a while. A lot of times people say prolonged sitting bothers them. So after we've sat and talked, I'll ask him, okay, you've been sitting for a while. Do you have any of your symptoms? but he didn't mention prolonged sitting. But I did want to check and see what happens when we change his sitting posture. And so I asked him to slouch, but I didn't use the word slouch. That has a negative connotation. I just showed him the slouched position and asked him to do that and let me know if anything changes. And it did. When he slouched, his left knee pain went away. And then when he overcorrected his posture, there was no effect. So those are good baselines. They can be good baselines. Next thing, I went ahead and got some baseline lumbar spine ranges of motion. And as you can see, um, on most of these, there was loss of movement at the spine and familiar knee pain produced with the movements of the spine. So those can be good baselines, although with this person, I never went back to these as baselines. I didn't feel like I needed to. At this point, I went ahead and checked myotomes. I didn't do any more of a neuro screen. Had him hop up on the table for a couple minutes and just took a look at strength and range of motion at the knee and the hips. And I think this is probably more of muscle inhibition than actual loss of strength. But I definitely checked range of motion of the knee as well, and it was moving just fine, which is another clue that it's not a knee issue, it's a back issue. And these knee strength tests could have been baselines. I could have come back and retested these, but I didn't. One of my favorite baselines these days is actually deep tendon reflexes. It's really cool when somebody has a hyperreflexive knee jerk and then you stretch the back out and their knee jerk is normalized. That's a pretty powerful baseline. But I didn't do that this time either. So after looking at the knee, and this was more like clinical theater here, checking his hip strength and range of motion. I wanted to get some functional baselines at this point. So I had him do a 30-second sit to stand test, which qualified him as a fall risk for a young man only doing 9 reps. I typically get asked about how much did that hurt you, 0 to 10, how much did that bother you? But I guess I didn't ask for that. But I definitely asked when I had him climb the stairs 4 times, and that caused 6 out of 10 left knee pain. All right, so now that I have my functional baselines, I'm ready to move the spine. So I had him do some repeated movements, 10 reps of prone press up, lumbar extension. And what happened there was he had pain centralizing from the left ankle. This is the first I've heard from him about pain in the ankle. But the pain went from his left ankle progressively up to the thigh, and it remained at the thigh after. It remained out of the ankle and in the thigh, so it's centralized. We like to see that. All right. And at that point, we went back to our functional baseline, which was the stair climb. And after the press up, set of press ups, pain dropped to 2 out of 10. So that's pretty good. Um, so went back to the table, said, let's see if we can do better. So added some patient overpressure, had him exhale at the top of the press up, 10 of those. And that cleared up the hip or the thigh pain. So now he's got no pain in his leg, and it remained better after. So at that point, I had him sit down again, and I had him trial a lumbar pillow to support a more upright sitting posture, support that lumbar lordosis. And I explained to him this can be important because this is putting your back kind of in the same position as that stretch that took your pain away and made the stairs much more tolerable. So as well as doing that stretch for homework, I want you to sit with this pillow. And at that point, I started to prepare his home exercise program, and I've made a mock-up of that here. One thing I love about where I work right now is I'm able to give people my direct phone number to my desk, and that's nice because we can solve problems over the phone, and I can actually get credit for that. Um, I have admin time um, where I can call patients back, which is nice when they take advantage of that. All right, so prone press up with lots of details about how to do it, what to expect, what to do if the pain peripheralizes or moves further down the limb. Um, I typically have people do this about every 2 hours, 10 reps while they're awake during the day. And I always, if I give this exercise to somebody with a lumbar spine derangement, I always give them this illustration too and explain to them, we want centralization, we don't want peripheralization. If you peripheralize, call me and we need to make adjustments. So I gave him sit to stand as well, just because he didn't do very well on that test. And then sitting posture with the lumbar roll. And these other ones, these were given on session 2, I believe. All right. And I did explain to him that this is something that can get better really quickly if you really lean into the stretch that you saw today got rid of your pain. Saturate your days with that stretch, get ahead of it, and that temporary relief will turn into a more permanent relief within days or weeks, typically. All right, my assessment. 39-year-old male veteran who presents with left knee pain, provisionally consistent with posterior lumbar spine derangement. Blah, blah, blah. Responded very well. Another cool thing about the VA If my patient needs a cane, a walker, whatever, lumbar roll, I can just give it to them. I don't have to worry about them acquiring it. My goals are pretty generic. Independent with home exercise program, increase LEFS score by at least 10 points. And this is a typo. This should be 48 because we want a higher score on the LEFS. So he scored a 38. And I wanted him to get at least 14 reps on that 30-second sit to stand, which would put him within the normal range for a 60 to 64-year-old. But hey, it's better than 9 reps. All right. And for chronic pain, I typically go for about 6 sessions. Try to get it done in 6 sessions. All right, visit 2. So this was a little while later. Remember, he canceled or no-showed or something to his follow-up. So visit 1 was October 28th. And then visit 2, December 8th. So kind of a long follow-up there. And when he came back, he said his right ankle is getting better slowly. Left knee has been pain-free with his home exercise program. But today he does have some radiating pain from the low back to the left hip. So the first thing that we did was that prone press up with the exhale. And I didn't ride it, but that probably, again, centralized that hip pain or abolished that hip pain. Then I probably put him on the elliptical for a few minutes, just get the blood flowing. And then we did some, functional lower extremity strengthening. Address the ankle a little bit with some dorsiflexion mobs. And updated his home exercise program. Gave him a seated banded heel raise just to help with swelling and blood flow. Ankle mobilization, lunge. All right, assessment. Blah, blah, blah. Patient responded very well with repeated extension, again, centralizing left lower extremity pain to the lumbar spine as needed, while the session focused on bilateral lower extremity functional strength and mobility. All right, visit number 3, January 29th, 2026. And this was the final visit. Patient states right ankle is still healing, but slower than he'd like. Today he did more work, more at work, and he had to take some muscle relaxers. His home exercise program is still helpful for the radiating symptoms from the back down to the left knee. Overall, the knee is still feeling a lot better with partial adherence to the home exercise program. He's definitely not doing it 6 times a day, but his knee is fine. Feels like he's ready to progress. Well, I asked him, do you feel like you're ready to do this on your own? And he said yes. So I went ahead and updated his home exercise program to return to function and prevention of recurrence stages of recovery. So what I did is I had him do a prone press up with exhale, 10 reps, and I made sure to encourage him to take note of how it felt. How high are you able to go? Do you feel like there's any kind of blockage or restriction or pain? And immediately after that 10 reps, I had him. So this is the return to function um, test to see if you're ready for that. Then I had him go the opposite way, laying on his back, bringing his knees up to his chest, lumbar flexion, just 5 reps. And I let him know, what is an acceptable pain during those flexion movements. Acceptable pain would be pain at the end of the range, pain that gets better with repetitions. Unacceptable would be peripheralization, obviously, pain in the middle of the range of motion, or pain that gets worse with repetitions. Immediately after he did those 5 flexion stretches, I had him do the prone press up with exhale again. And I asked him to tell me, does it feel better, worse, or the same than the last time you did it? And he said it actually felt even looser, felt better. So if he'd have told me, no, it kind of hurts this time, or I feel like I can't go as far, that would have signaled to me that he's not ready to move into the return to function phase. He needs to stay in the reduce the derangement phase, calm things down phase. But no, it felt better. So that became his new home exercise. Do some extension stretches, followed by flexion, starting in non-weight bearing. And I have a whole sheet that walks him through this. Every day you add a rep of flexion until you get to 10. Then you graduate to seated lumbar flexion, which is partial weight bearing. Start at 5, work your way to 10. Then you graduate to standing, full weight bearing. Start at 5, work your way to 10. And then from there, you can start holding weights, deadlifting if you like, and always just sandwiching it in between extension. And then I explained to him the prevention of reoccurrence aspect. Low back pain is something that, if you've had it once, you're very likely to get it again. But you can greatly reduce that likelihood if you make a habit of doing these extension type exercises, once or twice a day, as well as just walking more frequently and doing some kind of regular physical activity that you enjoy. So that combination of specific intentional stretching that kind of balances out those everyday forces on your spine that tend to be all flexion, combined with general exercise is a really good way. And of course, the posture correction is a really good way to reduce the chances of reoccurrence. All right, so assessment. Blah, blah, blah. Left knee pain consistent with posterior L-spine derangement, which is now reduced. He also experienced a work-related trauma to the right ankle, which is slowly improving, but still limits his ability to do heavy lifting and standing at work. He still demos mild bilateral lower extremity muscular power deficits, but these are improving. He has increased his lower extremity functional score from 38 to 57 points. I was really happy about that. 10 points is statistically significant, so he shattered that goal, um, indicating significantly improved perception of left lower extremity function. He's ready for discharge with updated home exercise program for return to function and prevention of recurrence phases of recovery. So we met goal 1, met goal 2, did not meet goal 3, but got to get him in and out and independent as soon as possible to get the next one in. All right, and the phrase that I love to type: patient will be DC with HEP. All right, y'all. Hope y'all enjoyed. Thank you for watching and listening. And let me know what you think.